Thank you very much indeed, and thank you for inviting me to give this quite difficult talk in a sense, which is that I've got 20 minutes to kind of talk about the entire question of delivering therapy for viral hepatitis, which is interesting in some respects, because obviously that means I'm not going to talk about vaccination. And when I first started doing what I do at a kind of global level, when I first started engaging with WHO back in 2007, there was not a single person out of the 8,000 employees that work for WHO with hepatitis in their job title. That's not to say nobody was doing hepatitis, but it was actually almost exclusively in vaccination, in the expanded program on immunization. And when I first broached the subject of viral hepatitis with them, they said to me, I don't know what you're talking about. We've got viral hepatitis under control because we've got Hep B vaccination. And the idea that this entire area they were doing nothing about and it wasn't really of interest is extraordinary. Obviously, vast changes have happened and things are very much better now, but that's how it began. Just a quick declaration of interest. The World Hepatitis Alliance receives lots of money from pharmaceutical companies. I don't receive any money, and I'm in fact completely unpaid, which may say something about my fitness for doing the job, either in terms of insanity or just stupidity. Anyway, I'd like to talk about sort of delivering therapy in a kind of broad way, and the whole point about delivering therapy is that there are an awful lot of steps that have got to happen. People have got to be aware and diagnosed, because you cannot deliver therapy to people who don't know they've got a disease. And then there's got to be this linkage to care, which we've heard quite a lot about, and access to people who can do proper assessment, access to people who are competent to prescribe the drugs. And in lots of cases, certainly at the moment, monitoring for Hep C treatment, and critically monitoring for people who don't at the moment need Hep B treatment but may do. And then regulatory approval and licensing has to be in place. And, you know, as was discussed yesterday, you can have a situation where tenofovir is licensed for HIV, but not licensed in a country for hepatitis B. And you've got to make sure when you've got generics that you do have high quality drugs. And something that people often don't think about is actually manufacturing capacity. You know, manufacturing millions of pills is not an easy thing, and distributing them and storing them. And of course, this question of price, which we have come to today finally, and is obviously very important, and it's necessary, but it's not sufficient. And what we need to make all this work is a number of things. We need political will at a global level. We need, which I will talk about, technical support at a global level, which I'm not going to talk about because I think Stefan's going to address that. And the resolution this year at the World Health Assembly actually specifically asked WHO to provide that support. We need political will at a national level, and we need funding and capacity and, of course, affordability. So I'll go through those one by one. Political will at a global level has been enormously lacking, and I would say that probably for the very first time at the World Health Assembly this year, I felt there was some kind of global political will. So during the debate on the new resolution, 50 countries actually spoke out strongly in support. And that actually included Canada, although Canada was one of the impediments to this resolution because, as you know, because as was referred to earlier by Professor Montana, the meetings, I think he described it at the Supreme Court between British Columbia and the federal government have been largely about harm reduction, and in fact the Canadian government did not like the expression harm reduction and refused under any circumstances to have those words in the resolution. But anyway, I think the point you get here is it's a very broad range of countries, developed, developing, right across the geographic spectrum. And that poster, by the way, was some posters we had at Geneva Airport to meet the delegates as they came to discuss it at this year's World Health Assembly. Political will at a national level, of course, has been the real problem. And a survey that we did with WHO last year, which was self-reported by governments, 47 of them said they had national strategies, but in fact only 17 of them really did, and as you know, Canada doesn't. There are more in development now, but this was recognized in the resolution by the fact that the very first clause of the resolution urges countries to develop their national strategies. But the thing we're critically missing is advocacy at national level to really push governments. And one of the reasons is that governments think, you know, here's a new program, how are we going to pay for this? And just a little comparison here, just a couple of the organizations funding other infectious diseases. The Global Fund with a $16 billion spend on HIV, $8 billion on malaria and $4.6 billion on TB. And PEPFAR with a budget for its first 5 years of $15 billion and the second 5 years of $48 billion. You know, we do not have that, and despite the fact that the resolution called on United Nations funds and programs and the particular agencies to include viral hepatitis in their work program, that's more a kind of optimistic plea than any kind of real call to action, I'm afraid. And as you know, the Global Fund and UNITAID are doing a little bit in co-infection, but nothing in infection. And the executive director of the Global Fund has been very clear that there's no likelihood of that happening. The only way that we're going to change that is to convince the Americans. And the way we're going to need to do that is to continually go on about the burden of disease. As you know, the Gates funded Global Burden of Disease project was initiated to try and find out where the Gates Foundation should put its money. In other words, where the burden was and where they could make a difference. And the 2010 figures, released in December 2012, showed that viral hepatitis kills as many people each year as HIV/AIDS, and 10 to 20% more than TB or malaria. And the 2013 GBD figures, released in July this year, show that, according to their estimates, the deaths from HIV/AIDS have now decreased quite substantially to an annual death toll of about 1.3 million. Which puts viral hepatitis up there as the leading infectious disease cause of death. Although, having said which, we can't do a direct comparison because we don't yet have the 2013 GBD figures for viral hepatitis. But we do need to continue to stress this. And we also need to continue to stress that we have solutions. So much of the big causes of death require lifestyle changes to alter them. If you're talking about diabetes or heart disease or lots of things. Whereas we have very effective treatment that can make a huge impact. In other words, we have solutions. And the big burden, good solutions. And I think that we also need very much to link viral hepatitis into the non-communicable disease issue. As you know, the NCD lobby bypassed even WHO and went straight to UN and to get a resolution and to get action on it. And viral liver cancer is now the second cause of cancer mortality. And I think it's good to note that the director of IARC, which is WHO's cancer arm, said on World Cancer Day this year, we cannot treat our way out of the cancer problem. More commitment to prevention is desperately needed. And we need to link what we do in viral hepatitis to cancer prevention much more strongly. National funding. If we don't have global funding, we're going to have to be very smart about what we do with what funds are available at a national level. And the resolution asked the UN funds to think about providing mechanisms to help countries with this. And one of the first things we need to do is to increase the priority of viral hepatitis within national health systems to make sure that we get an adequate part of the budget. And that again is about advocacy and about awareness. But we also need to look at, potentially new funding mechanisms. Whether, for example, we could look at bilateral support. There are a lot of donor countries, traditional donor countries, with strategic interests in countries where viral hepatitis is a big burden, and where the donor countries have expertise as well as money. And so, for example, you might think of the US and Egypt. And up until, I think, earlier this year, when there was no funding available, Congress had cut funding for military aid to the to Egypt from the US. A way of providing aid to the country is potentially supporting their hepatitis program. You think of Pakistan, which is a country with, again, a very high burden of hepatitis C, of huge strategic interest to both the US and the UK. Think of Western African, particularly the Francophone countries, very interesting to France. There are a lot of potential partnerships that we could help engender. We also need, what they did in HIV, I think very successfully, was to tie HIV burden into development. And we need to look at being able to do that in viral hepatitis. It's more challenging for hepatitis C because hepatitis B typically is acquired younger, and consequently its mortality occurs in a younger generation. And that means that you could potentially make that case. We need to see whether, for example, if we could, the World Bank would be prepared to loan money to countries. We need to make sure that hepatitis is in the post-2015 strategic development goals, and which is just sort of sitting in there at the moment under the universal health care, and whether universal health care can be used as a mechanism for providing funding for people to get treatment. And we need to look at personal loans. I've just been in Romania, where 5 banks are prepared to make long-term 25-year loans to people for them to buy hepatitis C treatment. And there's also some interesting developments in microfinance in the developing world as a way of funding treatment. All of these need to be explored, and we're right at the beginning of this. And the other thing we need to do is to use what we've got in terms of infrastructure and programs incredibly cleverly. And this was recognized again in the resolution about integrating viral hepatitis programs into what exists already. And for example, PEPFAR put a lot of diagnostic equipment into countries for HIV, much of which can be used just by changing the reagents for viral hepatitis. And in terms of capacity, there are so many people living with viral hepatitis that the capacity of the system to look after these people is going to be a real challenge, regardless of us being able to move treatment out of the ivory towers and into the community. If you think 90 million people have surface antigen in China, and you don't need to treat all of them, but you probably need to monitor a huge amount of them, how on earth are we going to do that? So we're going to have to look at this, and again, this is about using the infrastructure we have, whether that's for HIV, whether that's for other diseases. And we are going to have to find a way of prioritizing what we do in a way that is equitable. So I'm going to conclude by talking about the elephant in the room, which is price. And I'm going to talk about a couple of approaches, one in the developing world and one in the developed world. So I'll start with the developing world. There are a number of ways in which price can be addressed for the developing world. The first one is differential pricing, where pharmaceutical industry give different prices in different countries. And obviously that is happening with sofosbuvir at the moment, and also licensing agreements where certain generic manufacturers are given licenses and supported to do the IP transfer, and quality control ideally is provided. But they are selected manufacturers, so the competition is somewhat limited, and obviously it only covers some countries. You can make the competition freer by having a patent pool in which you put the IP, and then any pre-qualified company that manufactures generics can use it. And then you've got pretty much a free-for-all amongst generic manufacturers. Or you can set up local manufacturing in countries that don't have a patent system. But again, there's probably a big time lag there, because you've got to develop the IP or get access to it somehow. You can have patent opposition and do the same kind of thing. Or ultimately, countries do have the potential in public health emergencies to do compulsory licensing. The question in all of these is, what gets the drugs to the patients most quickly, and most effectively, and most cheaply? And it's not clear that any one of these is the answer. But clearly this needs to be supported by activism. And you know, the drug companies are, and I know there are lots in the room, you're all large companies, you're used to negotiating, you can look after yourself, and it's therefore fair for us to be jumping up and down saying you've got to lower prices. And it's very nice to see that in hepatitis C, that we're seeing much more proaction on behalf of pharma in terms of doing differential pricing and doing generic licensing. And so there's already a move to bring the prices well down in the developing world. And of course the media is a very powerful tool. In the developed world, it's a little bit different. And what we've got in hepatitis C is probably perhaps the first case where we've seen a massive divergence between cost effectiveness, which tends to be the barometer for judging whether healthcare systems should pay for something, and affordability. And I'm not sure where we are in bridging that gap just at the moment. And that means that I think we're going to have to really start negotiating price, and that might be around price volume, where we agree that if we triple the rate of treatment, we get a much lower price from pharma. The problem is that governments, by and large, are pretty useless at doing this. A lot of them have no experience of it. I actually suggested to our health system in the UK that they should go into the corporate world and hire some negotiators to do this. Obviously, they're not going to, but I'm actually very keen on this, because one of the issues is that from our point of view, we want to treat many, many more people. But governments don't necessarily want to do that. They want lower prices for sure, but I don't want a situation where all that's happened is the price has gone down and they still treat the same number of people. So I am very keen that farmers should use the leverage of price to increase the volume, but not just increase the volume, also to force on governments entire strategies, because that's what's needed. And my argument to the pharmaceutical industry is, if you do not insist with governments that prevention is part of the whole deal, the ministries of finance who are writing the checks, after a few years, will lose interest in the whole thing, because if the bucket is being filled as fast as you're emptying it, they're going to go, we're not going to do this anymore. So it is really in farmers' interest to insist on a strategic approach to viral hepatitis. And of course, with price volume, multi-year arrangements, there's risk sharing of possibilities. This is happening in some countries where the price actually is being determined by the SVR rather than the actual number of treatments. Competition, we hope, will have an impact on price, but I think we need to learn from hepatitis C and interferon, where actually two almost identical drugs did not for a very long time result in much price drop. You know, there are obviously trade-offs, which I'll talk a little bit more about later, and whether people will be prepared to accept that from a patient point of view. But if you have a drug regime that has the same side effect profile, but an SVR rate of 85%, and it's half the price of a regimen that has 95%, so you can treat twice as many people, and provided you're prepared to provide the better drugs to people for whom the first course doesn't work, is that a goer? We'll have to see. And again, activism here with trying to get and I apologize to those of you for Gilead, it's just that you were the first there, so you're the ones that people have been shouting at. And obviously the use of media. So what I would like to say is that this is an enormous issue, and I wanted just to give you the impression that there are an awful lot of players here, and they've all got to do their bits, and I think we're going to hear from the individual elements of those. But this is so big. We are starting so much from sort of point zero that we have a long way to go. Thank you.
Good afternoon. Thanks to the organizers for raising this issue and giving us a chance to discuss how we can take full benefit of this remarkable opportunity provided by the treatment. So I oversee the Global Hepatitis Program team at WHO. We're in the HIV/AIDS department, which we hope will soon be renamed to the HIV Hepatitis Department. And so we have our own activities, plus we coordinate activities that are done in the other parts of the organization. I'll give a sort of very high-level view of what the issues are, which have already been touched on, and then what we're doing about it. As Charles and others have mentioned, the Global Burden of Disease study really was a landmark because it gave comparable figures for the major causes of death and put hepatitis right up there among them. Despite that, the level of investment in hepatitis is very low. And if you think about it, there's at least 5 major reasons why this is true. The first of them, and I'm calling these the 5 needs that things we need to do to improve the scale-up services and to get towards elimination. The first thing is data. Really, that at the country level, there's very little surveillance data, very little idea of what the burden of disease is, which means that politicians then are able to ignore the problem and not get engaged. So the second part, so lack of data leads to lack of engagement at the national level because there's no advocacy and to convince politicians why this should be done. Similarly, a little bit of not much funding because it's not clear what the baseline is for burden of disease, where the infections are, so the donors don't see the need for it and governments don't want to fund it. There's a lot of hepatitis activities going in countries, immunization and others particularly, but in most countries there's really no national planning. So if we're talking about elimination and sort of a comprehensive approach, you need to have a plan that is comprehensive, that has targets, and that has timelines towards getting to them. And so all that accumulates to really a low level of services particularly for treatment. Some examples of that is, this is a slide from the Center for Disease Analysis showing despite serious efforts to find all published data on hepatitis C, the countries in gray are the countries that have no data available. So if you look at the continent of Africa, which is heavily impacted by hepatitis C, almost all countries are in gray, meaning that there are no studies. So, and really politicians particularly want data from their own country and don't want to know what the situation is in neighboring countries. So clearly a lack of data at the country level, which leads to confusion at the global level as to the estimates. Heiner mentioned this earlier in this meeting about if you look at all the estimates that are published, this was just an informal review of what estimates, what the estimates are for the global burden, and they range from a high of 180, and then most recently now 80 million, just published a couple of months ago. So if you don't really know what your baseline is, how many people are infected, it's very hard to develop targets, and it's also very hard to send a clear message of how serious the problem is. Funding is a dramatically underfunded mandate, and there are no data that shows what the level of investment is on hepatitis globally. So as a surrogate, we looked at the WHO budgets and divided the allocations per deaths from the global burden of disease study, and there's a 100-fold difference between the number of investments, number of dollars per death for tuberculosis and hepatitis, which is less than 70 cents of our budget goes per estimated death. Now, this is a reflection not of WHO's priorities, but of the priorities of its constituent member states and donors. All of that, most of that tuberculosis, HIV, and malaria funding is designated funding either from governments or from donor organizations such as the Bill and Melinda Gates Foundation, towards these disease priorities. So it's a really clear example of how there are the inequities in funding to deal with this issue. I mentioned the importance of national planning. Charles also mentioned it. I think it's critical that hepatitis be addressed in a comprehensive way, which includes prevention, screening, diagnosis, and treatment. We did a survey with the World Hepatitis Alliance, which indicated here in blue the countries that were reported having national plans or strategies, and there were 47 of them. When we followed up with those to really find which ones really had plans, we could only find 22. And those are North and South America are well represented, but the rest of I think the Scotland plan and in the French plan get a lot of attention, but the rest of the world really has no comprehensive plan. If you know of a plan that we don't have here, please let me know. We'd be happy to look at it. This is a very popular slide in this conference, and the point being that on the y-axis is treatment rate, x-axis diagnosis rate. The countries that are clustered here in the bottom are middle-income countries, and whereas these here tend to be high-income countries. So if you looked at a low-income country with a high burden, such as Nigeria or Cameroon, the diagnosis rates and the treatment rates will be really close to zero. So there's really very little diagnosis happening and very little treatment. So what is WHO doing to address these 5 needs? Now, what does WHO do? WHO has a convening role and a normative role, which means we hold meetings and we publish documents. But the fact that it's issued by WHO, which is the official health organization of the United Nations system, gives these policy and guidelines documents weight, particularly in low-income countries and middle-income countries, which look to WHO as they set their own health policies. So if we look at so these are the 5 needs, sort of at the global level, how we're approaching things at sort of the country level. We're going to be making a major increase in engagement around data. We'll be issuing this in the next year, sort of the first global report on hepatitis, which will illustrate some of the country examples, the data that's there. And at a country level, we'll be issuing surveillance guidelines, but also starting to develop a set of indicators that will allow countries to track the progress towards a scale-up of services. Because right now, we have no idea how many people are getting treated, how many people are, let alone how many people are getting cured. And really, we need to, sort of a global level, start to track that as well as at a national level. One activity that's going to take a lot of our time is this global hepatitis strategy, which we're initiating and will be a 1.5-year long process because it requires significant consultations at various regional and stakeholder levels. But we're starting that process next month with a small meeting to start to define what elimination means for hepatitis B, what are feasible targets, and what are priority interventions interventions that need to be scaled up to develop those to reach those targets. So the idea of the strategy, if our stakeholders come on board, will be that really it'll be around elimination targets for hepatitis B and C. Another area that we'll really be focusing on is the National Hepatitis Planning Initiative, which is right now a headquarters-led effort developing a set of tools that will allow countries to assess their burden of disease, to a sort of impact modeling tool that will allow them to assess how various investments will have, what kind of impact it'll have on incidence and on mortality. And then once finalized, we'll be at the country level, so doing workshops to work through countries to help them develop these plans that would include targets and budgets. Regarding treatment particularly, we're doing we issued hepatitis C guidelines earlier this year. Next year we'll be issuing hepatitis B guidelines and consolidated guidelines, and then helping countries to adapt those guidelines and include them in national treatment policies. We have to realize our team is very small. It's only 4 individuals, so we're somewhat limited in our capacity to do this. An important element is this multi-stakeholder engagement, which is the big word. I think we're really trying to build a momentum among the various stakeholders. One of the areas of priority is engaging with all the relevant stakeholders to reduce the price of the drugs, as Charles introduced. This has been a very busy year for us this year, so it's, I think the key elements that are of note is we had a global partners meeting in March, which was sort of our first initiative in developing this multi-stakeholder engagement. It led to a call to action, which was a broad range of interventions that should be scaled up. The launch of the guidelines was in April at the EASL conference, got a lot of attention. The first treatment guidelines on hepatitis issued by WHO, and was innovative in that included the recommendations on the newest DAAs. The World Health Assembly resolution, as was mentioned by Charles, these resolutions are really mandates both to countries and to WHO to increase its engagement. And it's really that document, which was really supported by what university endorsed, which gives us sort of the mandate to go forward and develop this global strategy. And so I think this is an exciting time, a lot happening, and really looking forward to this, to continue in this discussion around moving away from talking about individual interventions around prevention and treatment, and really moving towards a concept of elimination and with specific targets that will hopefully achievable. Thank you.
And it really is our great pleasure to be here, both to be part of this process, both to develop new medications and hopefully make them available broadly across the globe to patients who need them, and to be part of this very exciting strategy of potentially eliminating hepatitis both B and C. So what I'd like to do for you here in just a few minutes is to sort of describe our perspective on it. It took us probably about 10 to 15 years from the time that the first highly active antiretroviral regimen was developed to really optimize those regimens in terms of single tablet regimens, making regimens available even in the developing world that could be easily distributed. And I'll describe for you in a minute what some of the current status is of that program. And similarly, it took us about 10 years actually to develop the access program that I'll describe for you today. What we hope to do, and it strikes me here, it's actually a high quality problem to some extent, but after the recent approval of some of the new directly acting particularly hepatitis C agents, for the major focus of the discussion to be on access is actually a big step forward. There obviously are very important scientific questions that need to be answered, but obviously we've made great progress in terms of getting to where we are, and it's our objective to make sure that patients who need these drugs will be able to get them, and that access is indeed available both in the developed and the developing world. It's a process we'll all have to work on together, and we look forward to working with you on it. And I think a lot of the issues have already been sort of outlined, and in addition, I think there's some exciting or interesting new strategies we'll need to tackle as well, some important differences between HIV and hepatitis. So with that, Gilead Sciences, as I think many of you may know, is a biotech company based in California. We're just south of San Francisco in Foster City. When I joined about a little 20 years ago or so, we had about 300 people. Now we have 7,000 employees in 28 countries around the world. We have 16 marketed medicines and obviously a lot of ongoing studies in both viral diseases and others. It is our belief that all people should have access to our medicines regardless of where they live or their economic status. Let's see if I can get this to work. There's three real key parts, and I'd like to focus actually primarily on our access program and discussion, although I'm happy to answer other questions as well. Currently, Gilead Medicines, there's three parts to our access program. The first involves regional distributors. We don't have offices in every country around the world, so we depend upon partnerships with distributors to help make our medicines available. We currently have 20 regional business partners, and they cover 125 countries for us across the globe. And the vast burden of HIV is, of course, is in the developing world, and likewise for both hepatitis B and C, the vast number of patients that require treatment are actually in the developing world as well. We've divided it into access countries, which are the lowest socioeconomic countries, and then also emerging markets. These are the drugs that are covered in our access program. There's currently 8, soon to be 9. Primarily, most of these are mainly HIV drugs. However, Viriad, as you know, is also used for the treatment of hepatitis B. And of course, Sovaldi and now Ladipasvir for hepatitis C. And we also have a drug, Ambisome, which is liposomal amphotericin, which turns out to be a very effective treatment against visceral leishmaniasis. The other two components of the access program are generic licensing. We have 17 Indian and African licensees for HIV and for hepatitis B, and we have 7 Indian licenses for hepatitis C. Our voluntary licensing program involves full technology transfer, and we do ask or require that our partners seek WHO or FDA certification for the HIV program, and we do have a small royalty to ensure sustainability. There's certain activities that the company is required to do to allow the generic companies to be able to make the drugs available. We work very actively with our partners, and we found initially when we went into this, we weren't really sure how well it would actually work, but actually it's worked very well, and we've been very pleased with our ability to work with them, and we've then extended it beyond HIV, obviously, to our other therapeutic areas. The third component of the access program is actually intellectual property and a transfer of that. We actually work very closely with the Medicines Patent Pool to help craft the program that they have, and we were actually the first company to sign up with them and donate our intellectual property to them in 2011 for HIV. As you know, the Medicines Patent Pool at this point in time not directly involved with hepatitis. This is a list of, obviously, the first step in making these drugs available is actually product registration. Initially, in our access program, we made our HIV drugs available. We didn't necessarily register them. We made them available at cost pricing and figured that there would be ways to make them available within country. And we found quite quickly that was very low adoption, and you actually have to register the drug in each of the countries to really make it broadly available. So that was a process that we undertook beginning in the mid-2000s. We currently have 109 countries, and this is just developing world countries, in which we have a registration for Truvada, which is our combination product for HIV of tenofovir and emtricitabine, and also 109 for Viriad. We have a specific registration for Viriad for HBV. That's a separate indication, obviously, in 65 countries, and there are applications in many others that are currently pending. All of this is available, by the way, on the Gilead website. So if any of you are interested under corporate responsibility, developing world, and viral hepatitis, you can find a current update on our registration activities for all of these areas. Sovaldi's been approved in Egypt, and there's, I believe, 10 other filings that have been made and another 16 that are pending for that. And obviously, with approval of Ladipasvir, will follow as well. More than 50% of patients on antiretroviral therapy now in the developing world are receiving a Gilead-based medicine. So this is really the success of the generic drug program. The hope was basically it would actually allow us to scale up manufacturing so that we could meet the demand of potentially millions of patients in the developing world, and also to drive down prices. And it's actually done both. This is showing you in 2006 we had about 30,000 patients on tenofovir-based regimen. It's increased progressively. And the dark blue is the brand name Gilead branded medicine that we make available through our distributors, and in the pale blue is the generic medications. And currently in 2014 we have almost 7 million people receiving our HIV medications, and 99% of that is through our generic partnerships. So again, it's worked quite successfully in that regard in terms of providing the drug that can be made available for treatment of HIV. And similarly, it's also allowed the prices to go down dramatically, an 80% reduction since 2006 in the price of tenofovir. Our generic manufacturers tell us that despite their interests in terms of driving the price lower, it's probably not possible to get the price of Viriad much below where it is right now. It's about $5 a month, and that's simply because it's 300 milligrams of the product required. So it's more expensive, for example, than D4T or some of the other drugs that are provided at a much lower milligram amount. So just the cost per molecule has reached somewhat of a rate-limiting step. However, it may be possible to further reduce the price through additional innovation. I think, as been mentioned here before, there is a new form of tenofovir that's also being studied for the treatment of hepatitis B, tenofovir alafenamide, and the dose that's required for that is actually much less, 25 milligrams. So it's about a tenth of the dose of Viriad. So hopefully, if indeed that turns out to be an effective medicine for treating hepatitis B, it may be possible to further reduce the price of tenofovir-based medications by simply reducing the milligram amount. So for hepatitis B, it's available, again, Viriad is available in 125 countries and at the same prices as for HIV. And as I mentioned, Viriad for HBV is now registered in approximately 60 countries. For hepatitis C, again, there's a program that involves tiered pricing and also generic licensing I'll describe in a minute, and obviously working closely with various governments and selected programs. For hepatitis C, again, a tiered pricing divided into low, lower middle, and upper middle income countries. We use the same qualifications that the WHO describe, and actually the Gilead program is even we've classified some countries in lower categories than actually the WHO would. The intent, again, is to make it available, and also the burden of disease factors into the decision in terms of what tier it would go into as well. We've also licensed generic sofosbuvir to a number of Indian generic manufacturers, and the hope there is that they'll also be able to reduce, and I'll describe that in a minute. The registration of Sovaldi is proceeding, focusing on the highest burden countries first, and then we'll move out for there, and also medical education will be key as well. And about a month ago or so, a little bit more, we signed the licensing agreement with 7 generic pharmaceutical manufacturers to expand the availability of hepatitis C medicine in developing countries, and it included not only sofosbuvir but also the single tablet regimen ledipasvir, sofosbuvir, or Harvoni, for distribution in 91 developing countries. They account for about 100 million people, 54% of the global infected population. The companies will receive a full technology transfer, enabling them to get up to manufacturing more quickly than they would be able to otherwise. They'll be required to manufacture to the local quality standard in India, and they obviously have the ability to set their own prices and make their own combinations. They'll pay a small royalty to Gilead for product registrations, medical education training, etc. And we're hoping that large volume generic manufacturing will allow the prices to decrease as hopefully the demand to make these drugs available increases. This is a list of the Indian generic licensees. It covers 54% of the estimated HCV-infected global population. 75% of countries are designated as low-middle income, and 90% of the people living in low-middle income countries. Egypt was mentioned earlier. It was one of the first countries that we reached out to, and we're working actively with them to try to make initially sofosbuvir and hopefully subsequently Harvoni available there for them to be able to use it within their program. And I think you'll hear more about that in this session in a bit, in a few minutes. And again, this is the tiered pricing algorithm, and it's the starting point for negotiations with national governments, and it's determined on a country-by-country basis. As an evolution of this model, at least in HIV, it's been relatively unique and allowed us to make the medicines more broadly available than HIV medicines have been previously through other types of access programs, and the program itself has been recognized by the Access to Medicine Index and also by the U.S. Patent Office as providing an innovative use of intellectual property to better further global public health. The challenges, I think, have been discussed in some detail. The important major difference between HIV and hepatitis is there is no global fund or PEPFAR. There is no end user that's immediately willing to make commitments for large amounts of drug. This could be a bit of an impediment with the generic manufacturers because they obviously operate on very low margins, and if the desire is to get the price as low as possible, obviously having the volume as high as possible is helpful to them, and so clearly innovative strategies will be required to address this. I think Charles mentioned some of them already that are being potentially considered, and so it'll be interesting to see as we go forward in terms of how we might be able to put something together that will help make the drugs most broadly available. And obviously it will require commitment on the part of local governments to commit to both the programs, also the infrastructure and resources to make it available, the testing and everything else that's required to implement a program of this complexity. So that's all I have at this point in time.
I guess you could describe me as a stakeholder. You could also describe me, like many people in the audience, as a physician in the front line with an interest in seeing these diseases beaten in some way or the other. And essentially, I'm just going to give a few slides and leave plenty of time for discussion. So I guess the role of the clinician who has some interest at a national level, and again, that would be the case for many of the physicians in this audience, is to really try and understand and explain the experience on new regimens in hepatitis C to the policymakers, the local and national levels. And it may also require a little bit of explanation at local level. So we need to ensure that they understand the disease and its epidemiology, and we need data, we need collaboration from epidemiologists and public health specialists in order for the clinicians to promulgate what we see in the front line. I guess one of the roles that we have is to inform data for the pharmacoeconomic evaluations, which are all important where I work, and to ensure that with appropriate pharmacoeconomic evaluations, we can look at clinical utilization at a national level. At the clinical level, we need to really know how we can use this data to apply it in the clinic should there be some stresses placed on us, like prioritization. We, as clinicians, on a daily basis have to address the specific barriers that hinder the accessibility of these new regimens in clinical practice. I think increasingly, because these are high-cost drugs and they will be applied at some level of selection, we'll be required to inform, and this will apply in many different countries, the impact of these new regimens on the disease burden and on mortality and morbidity. And we'll have to have good databases and mechanisms in place to do that. And we'll have to provide education and training for practitioners. At the moment, this is being drawn centrally, but that surely can't be the answer for managing chronic hepatitis C in industrialized countries or in low-income countries. And we really have to expend quite a lot of time explaining how we can take this out into the community. At a hospital level, it behoves us all to ensure that we have adequate resources for patients' care. It's more than just being an empathic physician. There are certain safety issues. When you're dealing with patients who have advanced liver disease, cirrhosis, you have to ensure that they come to no harm. And we need to provide optimal care for specific groups, and we're examining the data very closely as it matures to ensure that we can argue for the appropriate duration of treatment. So where I work, and I don't expect you to read the slide, we have to make some sense of health structures, and the same would be true for wherever you work. But broadly speaking, hepatitis C, and this may be different when I get back home on Wednesday, is the responsibility of the NHS, a single payer. We don't have insurance systems, and what we have to do is inform the NHS of the disease, and we have to get some sort of buy-in from the NHS to provide treatment for patients. The NHS has relied in the past quite heavily on health technology assessments where I work provided by NICE, and there's a certain amount of tension at the moment, I guess, between NICE decisions and NHS affordability, but this is somewhere where clinicians really have to inform all of these decisions. And the structures are changing. They keep promulgating new structures for the delivery of care from the bottom up, with general practitioners, with specialists going out to the community. So it is a very unstable situation, and one that we really have to try to understand. So again, at a clinical level, what we want to ensure is how can the high cure rates that we've seen in the clinical trials, they are spectacular, unprecedented results. We are looking at sui generis results. How can we translate this into day-to-day practice and in some way see a meaningful impact on the disease? We've borne witness to this disease for a long time. What can we do to overcome the barriers at local and national levels? We have to interpose ourselves between the expectations of patients who want these treatments, physicians who want to apply them, the pharmaceutical industry who want to sell drugs, the payers who have to meet the cost of the drugs, and the regulators who want to ensure safe and effective therapies. And somehow the clinicians at national level have to be in the middle of all of that. We might be in a position to look at value-added pricing, other factors that ensure that we can optimize therapy should we need longer durations of therapy for these high-cost drugs for selected subgroups of patients. And most importantly, we as clinicians want to scale up testing and treatment. There are lots of hurdles to access. We need to look at the cost of drugs, which has been dealt with at length by Charles. We need to look at the delay in implementation and the effect this is having on individuals with end-stage liver disease. We fear being boxed into prioritization strategies, but that may be a necessity, at least in the first year or two of introduction of these very effective drugs. We want to improve diagnosis, and it's hard to see how clinicians, indeed working in ivory towers in hospitals, can widen efforts to improve screening and ascertainment, but we will rely on partnerships with public health authorities at a local and national levels. We also need to ensure that the less informed or those with social deprivation get equal access, and that's a clinical responsibility to inform government, and we need to overcome prejudicial attitudes, of which there are many in many countries. So what are the payers seeking? And this was alluded to earlier. Have clear goals been defined? I fear not. We really don't know how we're going to target treatments to have the maximum benefit on hepatitis C in a country such as the UK, and will differ from country to country. But we really don't know what the payers, what governments have in mind. Do they want to prioritize patients to restrict use simply because of the affordability issue? Is that the reason why this has been targeted to only the sickest, but not recognizing a need to treat all? Is this going to become a large legal question about denying access to individuals who may not have severe disease but want treatment? And how will we advocate appropriate uniform treatments at different levels in our own countries to ensure that we can harmonize treatments across Europe, across poor and rich countries, to ensure the best treatment with regional variations? So my last slide is we've made some success where I work. It's just an example. You'll hear a much better example from Manel in a moment. But we did manage to give some voice to the idea that we could use unregistered drugs, sofosbuvir plus an NS5 inhibitor, ladipasvir or declatosvir, for individuals with very severe cirrhosis with a Child-Pugh score greater than 7 who had prior decompensation. an individual with severe extrahepatic manifestations. And for us, there are not many precedents for this in the UK, but we did manage to persuade government to pay £20 million, that's $30 million, and that number's increased because we've exceeded the numbers of patients who've entered the program, to treat patients with end-stage liver disease. It's been a success for the NHS. It's been very carefully monitored in a very responsible way, and we'll soon generate data that will inform us how many patients have actually benefited from treating end-stage liver disease at least. It's the tip of the iceberg, but it's a start. There's some issues that I have, for example, that we're not treating patients who have resected HCC. I think that's a mistake. And we're also not able to treat patients with cirrhosis who failed telaprevir and boceprevir, who don't have Child-Pugh scores greater than 7. But those are clinical issues, and hopefully we can address them. So hopefully that leaves some time for discussion.
First, I'd like to thank the organizing committee for inviting me to give an overview about the Egyptian experience in management of viral hepatitis. Well, before 2006, the government did not recognize that Egypt had the highest prevalence rate of hepatitis C, and they were not doing anything about it. There was increased demands from the patients for treatment, and in late 2006, the National Committee for Viral Hepatitis was established by the Minister of Health, and we had very clear objectives at that time to assess the size of the problem in Egypt, develop a national strategy, a treatment program, and improve access of treatment to patients, prevention, clinical research, and management of advanced liver disease. Well, we conducted a national survey in collaboration with the Demographic Health Survey, and we identified that we have a prevalence rate of chronic hepatitis of around 9.8% of patients who are viremic, and the prevalence increased with age up to 25% in those above the age of 50. For those who are younger, between the age of 15 to 19, the prevalence was 3.8%, which is still very high. Prevalence was mainly connected with the medical interventions like injections, dental procedures, blood transfusions and surgeries, and the healthcare practices. We managed to improve patient access to treatment, and we developed 26 liver centers distributed all over Egypt. And during the past 7 years, we treated 360,000 patients with PEG interferon and ribavirin, and the government was subsidizing almost 95% of those treatments. They were actually supporting them fully. And optimal clinical management was attained for all patients, but pediatrics were not supported by the government. We had a special program subsidized through our NGO. I'm the Secretary General of this NGO and I'm Clinical Director of this program. And we managed to have a program for children in 7 centers in universities and teaching hospitals, and we've treated so far more than 700 children. Those are the centers distributed all over Egypt. As you can see, they are in access of most of the patients with high prevalence rates. The highest prevalence rates are in the northern part of Egypt, which is called the Lower Egypt. It's less in Upper Egypt, and then frontier governance, it's a very low prevalence rate. We're planning to expand by end of 2015 to 40 centers with the new therapies available. We also have a networking system that's connected to all liver centers that collects the data of all 360,000 patients. All the data are within the server system, and we have a very good database. For recent progress, we negotiated the price for SOF in March 2014. Fast-track registration and the memorandum of understanding was signed in July 2014. We had guidelines that were approved nationally by hepatologists in August 2014. The national patient enrollment for DAA was last September, and actually we opened the website portal for registration, and I'm going to show you how many patients have registered so far. From mid-September, the first patient started treatment on October 16th, and other DAAs will be introduced in 2015. Some are already under fast-track registration. Semiprevir has already been almost registered, and the Daclatasvir and the AbbVie drugs are coming very soon as well, and the Sofledipasvir. So if we look at how cost-effective is treatment, if we are treating, if we have a budget that's let's say £120,000, and we plan to treat by PEG-RIBA, we will have only 10 patients treated, only 5 of those will be cured of hepatitis C. But if we treat with PEG-RIBA and SOF for 12 weeks, we will treat almost 12 patients, and 11 of those will be cured, and we will pay £9,600. So this lump sum of money will be enough for curing 11 instead of 5. And if we have those naive, non-cirrhotic patients that have low viremia and can be cured, we can cure 15 out of 17 patients. And of course, we can, out of 9 patients, cure 8 if we give soft ribo for 24 weeks. So it's very cost effective now to start shifting treatment to soft ribo and interferon unless we have something that is more effective, and we are starting interferon-free drugs. This is the flow chart for the treatment procedure. The patient takes an appointment through the website, is being evaluated in the clinic, and there is a physician checklist, and then the enrollment sheet. Data entry comes from all centers to the central office, which is the National Liver Center. And then a final decision for regimen. We are prioritizing patients for treatment. F4s will start treatment first, and then we have those with extrahepatic manifestations. Liver transplant patients as well will be treated, and the decision will be sent online to the liver centers. This is the system where the patient registered. This is the first day. We had 103,000 patients registered on the website with known hepatitis C. And so far, until October 27th, last week, we had 590,000 patients who registered on the website who know that they have hepatitis C. And these are the age groups. Most of them are between the age of 51 and 60 years. So it's huge, of course. We are planning to treat 50, 60,000 in the next 6 months. We're scaling up to 150,000 the following 12 months, and then 300,000 by 2016, hopefully. And we are also expanding on the liver centers. This is one of the mechanisms we've put through, because the drug is strictly with the 1% of its original price available for the Ministry of Health, is strictly for the liver centers. So to prevent leakage of the drug outside the centers, we've created a QR code that has 18 encrypted digits, all belonging to the patients, starting with the patient's name, his birth date, his PCR level, and all those details. And then the patient has to break the bottle the first time, take the first tablet inside the center, return the empty bottle to take the second one by the following month. And if he does not return the empty bottle, he's out of the program completely, and he cannot come back to be subsidized or treated through the government program again. The last bottle the patient is going to take has a sticker. We remove the sticker. What's written on the bottle is that this bottle is counterfeit. So we can't take this bottle and go out and sell it. So this is just an anti-diversion mechanism that we had to put through, because this drug is 1% of its original price. And it's very tempting for patients to either share the treatment with their family members or to go and sell the drug to different countries. And in fact, we started to have counterfeit drugs in the market. As 2 weeks ago, we had an Indian counterfeit drug that was caught in one of the pharmacies in one of the governments. So it's starting already to be done, so we had to be very careful. So then we had launched also our action plan for prevention, and it's not only about treatment, but we launched also the prevention action plan that has all the components, starting with surveillance, infection control, improving blood safety. Our blood safety law, it's dating back to 1961, eliminating transmission. We are introducing the birth dose of hepatitis B for the first time. We started vaccination since 92 at the age of 2 months, but we started implementing now the birth dose. Of course, role and care treatment in prevention, and the communication strategy as well as research agenda. This is the plan, and in fact, we are fully supported by WHO, CDC, UNICEF in creating the communication plan and strategy, and lots of stakeholders from Egypt, including NGOs. This was the communication plan developed by UNICEF, and now it's in the implementation steps. And this is the modeling that looks at how we're going to eradicate or at least eliminate hepatitis C in Egypt in 2030. And if we only use treatment, we are going to decrease the prevalence to less than 5%. But if we also implement strict and stringent and vigilant infection control strategies and a good prevention strategy, it's going to be less than 1%. So I believe that the key of success to any program would be first to have data and situation analysis, integrate efforts, and empower and have demand from both patients, physicians, NGOs, organizations, scientific organizations, foundations, politicians, very important, to have media advocates, and this, I think, will lead eventually to government advocacy. Those are all the members of the National Committee for Viral Hepatitis, the WHO Technical Advisory Group for Prevention Control of Viral Hepatitis, and we have special acknowledgement really to the efforts of the country office of WHO in Egypt, who helped in printing out of the prevention plan and in creating the action plan. Thank you very much.
Thank you very much indeed for inviting me back. Obviously, you did that before you had the benefit of listening to my first talk. Okay, I will be very brief. What I want to say really about patients is our role in this is not to sit there and wait for everyone else to organize these fantastic services, deliver them to us, and maybe we'll take the pill if we feel like it today. We have got to be much more involved, and clearly advocacy is a critical part of this. If we don't speak out about viral hepatitis, how can we ever expect anybody else to do it for us? And frankly, we've been incredibly silent, and it's very depressing. I think maybe it was Jordan who showed a picture of sort of HIV that was just crowds of people and like 3 people with Hep C lying down. We don't seem to have a lot of get up and go. We've got and speaking as one, I think I'm allowed to say this, we've got a lot of lie down and moan, and we need to change that. And clearly part of that is tackling stigma. And also you've got to remember, there's somewhere between 300 and 400 million people living with chronic viral hepatitis. We should be able to make an enormous noise. And stigma, I just want to say, is very, very different across the world. There's a lot of it around viral hepatitis, but it just is different in different countries. And it may be in the developed world, where you have people who inject drug, migrant populations, indigenous peoples, a lot of marginalized communities. But even where it is very widespread, there's often discrimination, for example, in lots of Asia about people who have hepatitis B, denying them employment and education and so on. And we have to speak out to get rid of that. We have to normalize it, and we have to take it on ourselves to do that. And we need this advocacy to get action, and we need to make much better use of the media than we have. And again, it's about everybody working together with consistent messaging. And advocacy has a big role in making diagnostics and drugs affordable. And I didn't really talk about diagnostics, but diagnostics have the potential to be as expensive as the drugs, which is ridiculous. PCR tests in many parts of the world are just exorbitant, and that needs to change. Obviously, it'll help if we have drug regimens that need much less of that. And I do think we have a role too in supporting the medical services and also in research. And I can't remember who was presenting this morning about peer education, how effective it is. And we need to be involved in that, and particularly around reinfection prevention. And buddying is a incredibly important part of that, and that is beginning to grow, and I'm delighted to see that. But I think we also do need to say what we want and what we need in terms of services and how they're configured. Actually, if it is very difficult for us to get to secondary and tertiary care, we need to make that really clear, that services should be brought out to us where we can access them more readily, we're more likely to turn up for appointments and so on. And being clear about our priorities. And this is a kind of difficult one. Are we able, as patients, to see the bigger picture? Are we prepared to think about trade-offs? Are we prepared? The C word, I'm sure is compromise. Just in light of the current American elections. If we, as I mentioned earlier, if we don't have many side effects, are we prepared to try suboptimal treatment if it's much cheaper, on the grounds that we would then get the best treatment if it didn't work? We're going to have a lot of potential combinations, and the prices are potentially going to be very different. Are we going to be able to think about the public good and the public purse, or are we only going to be able to think about ourselves? Interesting question. and duration, and there are going to be a lot of factors, and how much trade-off are we prepared to think about? And I think it is incumbent on us to consider these questions. And again, with prioritization, you know, the wait, how long are we prepared to wait for treatment? What is a reasonable time? If a clinician says to me, look, you know, I have a clinic full of people with cirrhosis. You don't have cirrhosis. I will give you treatment, but will you please wait a year for it? What am I going to say? We've got to start considering these things. And whether, you know, we're prepared to trade simplicity for the very best possible care, because the very best possible care is not going to be available in lots and lots of settings. Certainly not if we're going to deal with the numbers that we need to. Thank you very much.
So the role of CDC is actually a simple one to summarize. It's my slides are advancing on their own. It's to improve the U.S. care continuum for hepatitis C, and that's through policy development, assessment, assurance, the three core functions of public health. So as an example of an assessment, really through population cohort studies, because our surveillance system actually doesn't monitor treatment outcomes, as you know, and is actually fairly limited, we were able to describe the care continuum through this New England Journal of Medicine article, and I think it's been defined, actually verified again in a recent meta-analysis. And so we see this tremendous gap in the care continuum that we all know and have seen multiple times. The second is policy development. Another example was the birth cohort recommendation to really improve detection of hepatitis C, which we know is severely underdiagnosed from the care continuum. And this was based on epidemiologic data. We used our prevalence data from NHANES, another population cohort, which actually isn't fully, doesn't capture institutionalized adults, so it does pose some underestimates, and came out with this recommendation in 2012, which didn't quite agree with USPSTF recommendation at that time, but their agreement in 2003 really changes how hepatitis C testing will be reimbursed in the US. Recognizing that we have a need for better diagnosis and clinicians need simple algorithms in their busy practices, we revised our algorithms to come up with a very simple algorithm that says if it's a positive antibody, please do an RNA, noting that clinicians aren't necessarily doing that next step. And what happens if you do have a detected RNA to link to care. A huge effort we've made is in raising awareness and education. I think all previous speakers have recognized the importance of this. And it's really done through multiple media mechanisms. Earlier today, I showed the airport dioramas. We've also done a lot of Google ad placements that's exceeded the industry average in the number of clicks that we've seen. We also actually, interestingly, have for both hepatitis B and C, have a self-assessment tool that patients who are thinking about going to a clinician for testing can actually take online and to help them make that decision whether or not to go and get tested. Recognizing the advancements in treatment, we've supported IDSA and AASLD in updating their guidance and really emphasized the importance of having a screening, testing, and linkage to care section, which now does exist in the guidance. And getting to the assurance function of public health. Earlier today, I described the programs that we've implemented for testing and linkage to care in settings that do serve high-risk populations. And these serve not only to address the needs of those populations, but through these programs, we learn about best practices. And so I'd mentioned that in the last 2 years, we've served 24 sites that serve injection drug users, community health centers, really focusing on birth cohort testing and other settings, including emergency departments, and there's some interesting data coming from that, and the benefits of actually testing in emergency departments, which does serve a very high risk population for Hep C, finding prevalence rates of as high as 11%. And now we're learning from that experience that we can succeed in testing, but linkage to care still remains a problem. We've beefed up the program and now funded fewer sites with a greater emphasis on really building healthcare capacity to test and cure. And that's through training primary care physicians to test and treat, and in many instances using the Project ECHO model that we learned of today. As you all know, the U.S. is undergoing health reform, and quality of care will be reimbursed, and there's an incentive for quality, value-based care. So we've already started working with AMA that develops performance measures, actually in 46 clinical areas, and 50% of the performance measures that are in circulation belong to AMA. And they revise their measures every 3 years, so we've participated with them to review their existing measures to ensure that screening is addressed, linkage to care is addressed, and achievement of SVR is addressed as a measure. And so these have been voted in by AMA, and now we're in the process of trying to get them endorsed through the National Quality Forum. The ones that I've highlighted are actually brand new measures that were developed by the AMA, and we hope to implement in coming time. And we've actually already begun to work with HHS, our Office of Health Information Technology, to begin to e-specify the screening and linkage to care measures. That's the first 2 measures that are there, so that as clinicians implement EMR, they can adopt these measures and report them to CMS. So we can actually also monitor through clinician practices how people are testing and caring for their patients, and whether the quality of care is what it should be. So in summary, some of the efforts towards assessment, policy development, and assurance have included coming out with a broader testing recommendation that's risk-based and includes a birth cohort. We've had we're doing multiple efforts to increase the uptake, such as education, capacity building, implementing performance measures. We've started to now develop community-based programs that improve the healthcare capacity to test and cure Hep C with better linkage to care. We really recognize that's key to recognizing the full potential of the great treatments that we have. The challenges we have, as we all know, remain underdiagnosed. That Hep C is still, despite all these efforts, is underdiagnosed. We have to get our clinicians to start testing with an RNA test, which might seem simple to us, but in practice it is more difficult. Access to care, and cost of medications, that is a big challenge for us. Thank you.
Now it's time for a discussion, and unfortunately we do not have a full hour. I really want to stop the discussion a little bit after 6, because some of the speakers here behind the table have to catch their plane, and Jordan Feld has to present the Toronto Declaration on Global Eradication of Hepatitis on behalf of a group of key opinion leaders. So if you have questions, please come up to the microphone. Don't hesitate, but maybe keep them a bit short. If we don't have too much time. Let me start off with a question to Jim Rooney. You gave a lot of initiatives on providing cheaper drugs in the developing countries, but obviously in the developed countries we also have a lot of patients who are not treated because of these price problems. What initiatives can we expect there?
Well, obviously, access remains a priority for us, not only in the developing world, but also in the developed world. And as you know, the process for doing that is complicated and varies by country and involves individual negotiations, and I think can be individualized in countries based upon the infrastructure that they have there and how they plan to eventually use the drug. I don't know if I can generally, answer the question in any sort of a more specific way for you. So I'm obviously on the medical side, not on the commercial side. Yeah. So I don't want to duck the question. I'm happy to try to answer for it as best I can. But we do recognize that we don't want any patients who need the drug not to be able to get it because of pricing considerations. As you know, the existing pricing is based upon essentially the cost of a cure, and the price for the existing regimens with Sovaldi have been compared to other regimens that were out there previously, including PEG-RIBA and with a protease inhibitor. And we've tried to make them at least comparable. I think part of the big problem has been that the regimens now that exist are obviously safer, easier to take, and more efficacious. So the demand has become so much greater than had been anticipated, at least in the U.S. initially by many of the payers. I think they were taken aback a bit simply because they didn't anticipate that the demand would be what it is. So that's really been as much the problem as it has been the price. Obviously, as we came forward with a combination drug, it's not priced at twice the price of Sovaldi. It's at an increment above Sovaldi, and it's actually a substantial improvement over the cost of if you had taken Sovaldi and Cimeprevir, for example, in the U.S., the price was close to $150,000. I don't know the exact numbers, but somewhere in that ballpark. So obviously being under $100,000 is substantially better and a move in the right direction. There obviously are, the U.S. system is quite complicated in terms of how drugs are delivered and the negotiations that are ongoing with various different pricing groups. And similarly, negotiations are still ongoing in Europe. The system there is quite complicated as well, which involves individual negotiations on a country-by-country basis once the approval of the product is made in the EMA. So we'll continue. We want to hear what what your concerns and your issues are. We want to work with you to try to make it available to patients who need it. And so all I'll say is, please communicate with us, and we'll try to work with you to make sure that patients who need the drug have access to it.
We will. Very good.
So two questions, one for Manal and one for Jim. Manal, you've started the treatment and you're going to treat 60,000 plus people for the next couple of months, I presume, and hopefully you get more drug later from Gilead or whoever to continue the treatment. What about outcome? How are you going to look at outcome in the patients? Can you tell us more on, it's very nice to treat them, but what is the outcome database going to look like, and the eventually reporting on this?
Well, I think what we will do now as pre-enrollment, we're having all the data on the database, and we will request that patients will be tested immediately after finishing the course of treatment, and they have to come back for another test 6 months later. That's what we're planning to do for the first coming patients, to learn a little bit more, because this is also the clinical trials that have been done. It's very small numbers. So I think this is sort of phase 4 trial, can be considered as a post-marketing study in the next few months. We will learn a little bit more about what we need to do and what kind of regimens, also combinations, we need to do in the future, because it's really complex how we're prioritizing patients now. And if we're just waiting to see all the data and see if we have more than 60,000 cirrhotics, what are we going to do? Who is the top priority? So we're trying to have ways of prioritizing really the patients in need right now. It's too much for us, 600,000 patients so far. It's a lot of work. We have so many teams working on the data, on the clinical files of the patients to just extract the data that's really required to be able to prioritize patients. So I think on a monthly basis we'll be able to know how things will go.
So you said you're going to go for 6 months. How about longer than 6 months? Are you going to let them come back to see if there's a reinfection or whatever, say a year later?
I think we need, because the numbers are huge in the centers, we will not be able to do this until we expand on more centers, because it's the numbers are too much. Already we're having patients coming twice, first schedule and second schedule. Now the liver center, for example, receives 1,200 patients a day, which is a huge number. So patients come back, first visit for their tests, and then the physician examines them, he puts everything on the file, he tells them come back with the following tests, you have to come back again. He comes back for a second appointment, and others would have a first appointment on the same day. So it's tremendous work, and lots of physicians. Initially we trained 1,000 physicians and nurses in the liver centers, but I think we need to do much more. It's very hard work.
So the next question is thank you very much for clarifications. Next one is to Jim Rooney, who I've known for more than 30 years, I guess. Glad to see you here at this meeting. I wanted to know, I mean, first of all, congratulations on what you're doing all over the world, but you're missing one part in your presentation, and that is the middle countries. What are you doing in the middle countries?
Well, we do obviously have a tiered pricing system. So there's access countries that are the lowest tier, and those are the ones that I listed on the slide. And then we have both lower middle lower middle income and upper middle income countries as well. And again, they're categorized based upon criteria, World Health Organization criteria. And again, our criteria for categorizing them are oftentimes more liberal than would be the WHO, and takes into account the disease burden in those countries. So again, we're very early on in the process. Again, prices are just being negotiated with local governments in many of those locales, and as we go forward with that obviously will be something that we'll continue to look at it on an ongoing basis. But the intent is obviously to make it available everywhere that it needs to be.
Stefan, I have a question for you. We heard from the HIV field they want to try to reach 90% treatment coverage in certain areas in 2020. Does WHO have any figure in their mind? And obviously it will differ from country to country, we understand that all, but what level of hepatitis B and C patients could be treated in that year? Let's say if you take a 6-year time span from now, what is the aim of WHO to reach, basically?
Currently, we don't have specific numbers or even ranges. But I think at the consultation we're holding next month, it will be the beginning of that. So it's figuring out what appropriate targets would be and how to and what strategies to reach those. I think as compared with the HIV model, I think the big limiting factor is a lack of large-scale funders, and I think that's what made the PEPFAR Global Fund. That's what made those 90-90-90s feasible. I think that's going to significantly impact what's feasible to do, since the sense is that countries are really going to have to fund this on their own. So I think, as I mentioned, this is really. We're beginning that process now to bring together a group of experts to try to look at the modeling to see what is feasible and what can you achieve with treatment as combined with prevention, and then try to develop targets. And then it's going to be a significant effort of consultations to make sure that there's buy-in around those and that these are felt to be achievable.
Because the problem of the funding, and I experienced it both in Europe as well as here in Northern America, where you try to get funding, is you say your 5 needs are more data, more engagement, more funding. But to need more data, you need funding, basically, and very often that's not given. And then governments tell, well, liaise with the pharmaceutical partners, with industrial partners, and then your results are sometimes even considered as tainted by them. So it's like a vicious circle, which is very difficult for us to break through, I would say. Do you have any suggestions?
I mean, certainly, the cost of getting good data is a lot less than the cost of treating on a large scale. But the people, there isn't a lot of enthusiasm to fund surveillance or surveys, and I think that was one of the strengths. If you compare the HIV experience with the hepatitis, is that there was really a significant effort to get good estimates, or consensus estimates. That was one of the key functions of UNAIDS. They developed this whole infrastructure of going to countries, reviewing their data, and putting them into a unified model, the spectrum model, that gave numbers that everybody could come around. So, and then combined with the significant efforts to do population surveys. So it was the organizations, the global funders were willing to fund it. But you're right, it's where do you start? And right now the country's really there's real opportunities. There's all these HIV surveys that have been done. And if those samples could be tested with for hepatitis, you could rapidly fill in that map, which is all gray, with reliable figures, and it wouldn't cost that much money. But even for that, the money isn't there.
Peter?
I'd like to come back to Dr. Shinazi's question. I mean, for example, Eastern Europe, I give many lectures there and try to tell them how good your drug is, Sovaldi. And then the uniform answer is, we are happy to get Telaprevir. And it may take 5 years before we can get the better drug. I think it's an ethical problem, and I think there's an urgent need to make the drug available for Eastern Europe. I mean, I'm living very close by in a country which has no limits to prescribe Sovaldi and Cimeprevir and Daclatazvir for most of the patients based on the current local law, because insurance companies have to provide the best available and best tolerated treatment. So they have no option. If they deny a prescription, the judge has to decide, and they're going to lose. But that's a unique situation. So what are you really doing about Eastern Europe?
Thank you for the question. And obviously, Eastern Europe has a major problem both with hepatitis C and also with HIV. And there also, of course, needs to be a commitment on the part of the governments to work to make treatments available as well. And that's been an issue certainly for HIV. Hopefully, won't be as much of an issue for hepatitis C. But we certainly, our plan is to make the medication available in Eastern Europe. Some of them are actually part of the access territories, I believe, for HIV. Yeah. Yes, well, yeah, but yes. So it depends what part of you're talking about, the Ukraine, or whether you're talking about.
I'm talking about Hungary, the Czech Republic, Romania.
Right.
All of them are part of the Europe.
Sure, part of the European Union, yeah. So obviously it's part of the process. The approvals granted for Sovaldi within the European Union, then there's individual negotiation with each of the countries on a country-by-country basis in terms of pricing and making it available there. So that process is ongoing. And as you know, in Europe, it starts with some countries and then moves systematically, usually from the highest income countries, starting with Germany and England and France, and then going to the Mediterranean countries, and then through Eastern Europe, Greece, etc. And it's that way for HIV. It's that way for, I think, most medications.
My question is, are you planning to offer them a lower price?
So again, that's a complicated question, and I'm probably not prepared to answer it. But it is, we do want to make the medications available there, and we're happy. If you have questions about that or whatever, you're welcome to contact me as well. And I'm happy to keep you updated on where we are and what's going forward. We recognize there's a problem there, and that we do want to make our medicines available.
Okay. Microphone number 2.
Oh, yeah, I just wanted to support the idea of tiered pricing. I think most patients understand tiered pricing, and they think it's fair that people in the lower income countries have to pay less. But I'd like to also support the people that said China, Brazil, Eastern Europe. The middle income countries are not currently included. And also to think about, I wanted to ask you about if there is any consideration for whether a country has a national insurance plan, because if it doesn't, then the poor in the middle and upper income countries are excluded.
It's a question addressed to me, I guess.
Yeah, they're all addressed to you. We're very sorry.
As I mentioned earlier, it's to some extent a high-quality problem to make the access the major issue, and this is a scientific conference too, to discuss scientific issues. So obviously we have many important scientific issues to address, but access obviously is a key issue. It takes some time to work all of these things out, as you well know also. So we remain committed to try to work our way through this. Usually we identify obviously access in the developed countries and in the access countries oftentimes first, and then the process moves through the lower and middle income countries as well. And it's still being worked out for HIV in some of those places. So our intent is to make it work through those issues as quickly as possible. And the access program that was announced is sort of a first step, and obviously a lot more needs to be done to fill in the gaps between the developed world, the access program, and what's going to be happening in the lower and middle income countries.
Okay. Jordan, a question for Jim or for someone else?
I have one quick question for Jim and then another question, a more general question. The quick question for Jim is, in addition to pricing, there's also the issue that has been raised multiple times today about getting people linkage to care and particularly access to fibrosis staging. And I'm wondering whether Gilead and any of the industrial partners have thought about that part of the role, because that, I mean, obviously there's an upside for you, but there's a huge upside for patients to be able to get through that continuum of care. And right now, as everyone showed today, they're getting the diagnosis and then nothing happens. So I'm wondering if that's part of your plan.
Yeah, no, sure. I'll try to make a brief answer to that. But obviously in HIV, the same thing is an issue in terms of both testing and linkage to care. And actually, we have a specific part of our organization that focuses on that, on testing and linkage to care, and work very closely with groups both in the U.S., Europe, and elsewhere to try to improve the process, which has many challenges, as we've already discussed today. And certainly access to diagnostics that would help improve patient care is a key component of delivery of effective therapy. So that is something we'll continue to work with various partners going forward. And I'm sure it'll vary by country and geography in terms of what's required. Part of the problem is the infrastructure doesn't exist in some places to support the care that's going to be required to be delivered. So it's more than obviously a Gilead problem or a problem for even any of you in the room that would want to solve it. So it's going to require a partnership between the company, between healthcare providers, and between governments to try to identify the best way to make these available.
Can I follow it up with another question? So this is not for Jim. This is a question about the data, and I guess there's been a few discussions about the global burden of disease study, and I think, Stephanie, you showed nicely the different ranges of prevalence that people have shown for the global burden of Hep C, just number of infections, and it's sort of all over the map. And I think it speaks to the fact that in many countries the data, as you showed, are just not there. And I struggle a little bit with the idea that we should put out a number when we really don't know what the number should be, because sometimes having it gets written down as almost fact that it was 170 million, and now there's this paper saying it's 80 million, and I know that that there's some rationale for lowering that number, but the reality is, as Greg mentioned, I think other people mentioned, a few small assumptions are wrong in that paper, and actually it's more than 170 million. It's higher than previously, and we are competing with, in a sense, with other diseases. And when we make a statement where we say that the prevalence or the burden is lower, and we're really making that on that whole sub-Saharan Africa being gray on that map with no data. You take a country like Nigeria with 120 million people, if we get the prevalence wrong by even a small amount, it totally changes the world burden. And I guess I'm just wondering if there's how you move that forward, and what other diseases did when they tackled this in the GBD project.
What other diseases did, I think HIV is always the most relevant example. As I mentioned, there was a significant investment because of the overall large amounts of money that was available. So significant investment to move away from antenatal clinic surveys to general population surveys. So really a tremendous improvement in the quality of the data. I think I guess we need numbers. Everyone is looking at the same studies, because the way all these estimates, it's systematic reviews of data, and then you you exclude different studies, you include different, you adjust for HCV antigen, and so. But I think fundamentally, I don't think it makes, I mean, it doesn't make that much of a difference. The approaches, the issues are the same. People are not being diagnosed, they're not being referred for treatment, they're not getting treatment. So whether it's 80 million, 170 million, there's still a lot of people who need services. So I guess we need some kind of a number. I don't think, I mean, it does cause confusion, but that's not the big problem. The confusion around numbers is not the real issue that's keeping people from being treated. So I guess, and the only way to improve it is to generate better data, and that's going to require investment.
But the only one challenge, though, I mean, I agree, confusion isn't the major problem, but prioritizing the way governments plan is a huge problem. When we do some work in Ethiopia, and there's two estimates for the prevalence in Ethiopia. One's 1.1% and one's 11%. That's a pretty big difference. And obviously that has huge implications for how the Ministry of Health thinks about planning for hepatitis C. So I guess that's where it is a big issue.
Yeah, you would hope that confusion would lead them to, the Ministry of Health to invest in surveillance. But surveillance is a tough sell, it really is.
Charles, you want to comment?
Just briefly, I mean, I think we do need a figure. I think just saying we don't know is, it's too difficult. We need something from an advocacy point of view. What I think we should do is actually use a range, because the range is actually more scary. And the range highlights the fact, if we've got a range of, basically 100%, that just says this is a mess. And, it could be this big.
Greg Dorr?
Just a point around the Global Fund and maybe a historical sort of perspective on how the TB sector and the malaria sector got inside the tent, and why viral hepatitis can't join them. Obviously, they lobbied hard, and there was various reasons why it was HIV/AIDS, TB, and malaria. So just some discussion around that, and why there does not seem to be an appetite for viral hepatitis joining. I know there's been some issues in terms of the investment into the Global Fund recently, but there must be other explanations for why there's no appetite at the moment.
Well, one of the things is that, if you remember, there was some figures put together at the time of the MDGs around the mortality, and it just looked at, unfortunately, mortality from acute viral hepatitis.
They did chronic. They didn't do cirrhosis or liver cancer.
Yeah, okay. Right, yeah, they didn't do cirrhosis or liver cancer. They didn't do the sequelae of it. And the point, as a result of that, it seemed like it was quite a small problem. The other issue is that essentially until 2010, viral hepatitis had never been looked at as one single issue. It had always been addressed as the different components. With reason, they are wildly different, and we struggle with World Hepatitis Day every year trying to get a message across that covers A through E. So I think that was a lot of it, and the problem now about getting it inserted is the issue that it is such a big problem. The size of it is actually working against it being included, in my view. It's the sheer scale of what you need to do and the consequent cost.
A question to the physicians, to Dr. Dushayko and Dr. El Sayed. So, considering the number of patients that we have, as Charles just mentioned, we need to embark on treatment probably by general practitioners and nurses. To what extent is that happening in the UK and in Egypt? Maybe Jeff, you can start. And how would you like to organize that in such a way that it runs well?
I think it's a good question. The nature of the program in the UK at the moment, because it's targeted towards patients with end-stage liver disease, is that it's all central. There are 15 designated units. Only those units can treat. We have to have a network where patients are referred. So we're a long way. But I think as treatment filters down, and hopefully that won't take long, or filters up from individuals with minimal disease, we'll see that treatment being given to drug and alcohol treatment centers. That would be excellent at treating. They did well with peginterferon and ribavirin, but the scale was too small. It was taken away from them with the introduction of telaprevir and boceprevir because of the complexity of using those drugs. That was a mistake. So it was taken away from those treatment clinics. It's time to go back to those. And then I think we could in the fullness of time, get this out into general practitioners. My understanding is in the US, 85% of hepatitis B is treated in primary practice. When we have a single pill a day for hepatitis C, that's uncomplicated hepatitis C, that doesn't have advanced fibrosis, there's no reason why it couldn't be placed in primary care, and certainly in drug and alcohol clinics.
Egypt?
Yeah. I don't think that's possible at the moment, given the fact that we're having the drugs at a certain price, specifically for Ministry of Health. They're not available even in the private, for people to buy from anywhere. So
about C, right?
I'm talking about C.
But B
and B as well. We started the program through our liver centers as well, but B is being treated everywhere. So it's not by general practitioners, by hepatologists, gastroenterologists in different hospitals. They're not restricted to the hospitals or the liver centers. The restriction for the liver centers is for patients who are not paying for themselves and they want to be treated at the expense of the government. So they either go to the national insurance hospitals or they go to the liver centers to be treated at the expense of the government. Or otherwise, if the patient is paying for himself, he can be treated anywhere. So that's up to him. But for hepatitis C, I think that's going to be the future eventually. I think if we want to eradicate or eliminate hepatitis C in Egypt, eventually it has to go even to the primary healthcare units. So when the treatment is even simpler, less monitoring, interferon-free, maybe the single tablet, maybe a shorter course, that's eventually going to happen, I think, in primary healthcare units. If we're planning to do something like we did with bilharziasis, we managed to decrease the prevalence of bilharzia in Egypt from 70% in rural areas in the 60s to less than 1% by 4 tablets that were given to everybody in primary healthcare units when they were infected. So I think that's the future, maybe in the coming years, that we're going to have a program like this when the course is shorter, treatment is cheaper, available everywhere, and can be available in primary health clinics. We're having a model with MSF, Médecins Sans Frontières, now in a small village in Fayoum, and we'll see if we can have a sort of a small eradication model and see if other NGOs can help in organizing something like this in different parts or in remote areas.
Dr. Ferenczi?
You mentioned activism is not necessary. Now the problem is, what I see is patients are not active because of the stigmatization they have. For example, when boceprevir was introduced in our country, Merck had a campaign showing a drug addict injecting a drug with the label, also you could have hepatitis, go for testing. This made a tremendous bad impact, for example, just to label them as drug addicts. And so what type of activism do you expect can be done to motivate people to go in these crowds to the streets, which was shown for the HIV group, which was full. And I organized something in Vienna in mid-July, and 20 people showed up. So they...
Is that a question for Charles, or maybe Dr. Mituka can answer that one? Charles first.
I mean, stigma is a big issue. There's no question about it. But you have to remember that HIV is being incredibly heavily stigmatized, and that's not stopped activism. One of the things, the point I was trying to make is that unless we as patients start talking about it in large numbers to show actually globally how common this is, essentially until we get over our own issues with it, we're not going to make much progress. And I do also think that there's and whether it's partly the constituency, it's partly the disease itself, I would suggest that the type of people who get it are not necessarily the type of people who are most willing or most able from a physical or mental point of view to get out there on the streets. So I think that's an unfortunate aspect of it. But, you know, if there are 300 to 400 million people, there are enough people to make a noise. And we just have to encourage it. And if you remember in HIV, you know, it took some time in some countries for people to, you know, it would really help if we had a lot of celebrities come out and talk about it. But again, you've got to get rid of the stigma before they are prepared to do it. So it's one of these slow little bits at a time, drip, 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 and eventually we'll get there.
It's on.
Oh. I mean, I agree with that. I think that we don't have that level of patient advocacy as we did for HIV. I think in terms of message crafting, you know, we've seen the importance of at CDC the investment in message crafting, and even you know, some of the things that I've shown requires a lot of pilot testing in various communities and ensuring that it doesn't backfire, and then inadvertently you're not stigmatizing a group through a message that that you intended to create to actually address the disparity in that group. So it's a tricky thing, and I think a lot of thought should go out into messaging before actually implementing.
Okay, thank you very much. It's 6 o'clock. Thank you very much.